Hello and welcome to the channel. If you are new here, then hi, my name is Brittany and I am a nurse practitioner. If you are a returning subscriber, then welcome back. Happy to have you here as always. Much of my content that I create here on this channel is educational, not only for the licensed nurse practitioner, but also our nurse practitioner students. And as you may know, I have completed multiple different nurse practitioner boards reviews in the past. I've done them here on YouTube, and then I've collaborated with the company Archer as well. And now I've just taken to my material once more. I've revamped it again. I'm offering it here on YouTube and then also on Patreon. So for today's lecture, we're going to be talking all about women's health for the AANP and the ANCC exams. But this video here on YouTube is a shortened version. To get access to this complete video and the complete audio files for the nurse practitioner licensing exam, then follow the link in the description box below and that will take you to my Patreon. The total review course launches on February 27th on Patreon, in which you pay a monthly access fee. Please enjoy this free video here to help you study, and to access those complete audio files, make sure to become a Patreon and join the tier titled ANCC and AANP exam prep course. Again, that complete course does not fully launch until February 27th. I just want to make sure and give you guys lots of sneak peek information on what is to come. So without further delay, let's just dive into women's health for the nurse practitioner boards exam. All right, so let's start the discussion with some important information on birth control. So there are a variety of birth control options available, and it's an important job for the provider to educate the patient on their options and then of course assist them in achieving whatever their reproductive goals may be. So like I said, there are a variety of options. Some are more effective at contraception than others. The most effective agents that we have for providing contraception include an IUD, so an intrauterine device, tubal ligation, vasectomy, or an implant. And it's estimated then that less than 1 per 100 women become pregnant using these methods each year, and they're considered a first-tier form of birth control. Second-tier options include combined estrogen, progestin, oral contraceptives, there's injectables, the patch, the ring, and these are estimated to result in 4 to 7 pregnancies per 100 women each year. And then the least effective, or that third tier, is the withdrawal method, condoms, spermicides, fertility awareness-based methods where they're tracking their cycle with their intercourse. Those are the least effective. So as a prescriber, it's really important to know contraindications for medications. So we're going to stop and talk a little bit about that now with combined oral contraceptives, because there are a few to consider here, and these are definitely important for your boards, of course, in practice as well. So contraindications to the combined estrogen, progestin, oral contraceptives include patients 35 and older who smoke 15 or more cigarettes a day. However, caution should still be taken with patients if they report smoking less than 15 cigarettes a day, because there is still an increased risk. And as always, it's so important that we weigh our risk and benefit. They're also contraindicated in patients with established cardiac disease, or if they have multiple risk factors for cardiovascular disease. They're also contraindicated in patients that have hypertension and a systolic of 160 or greater and a diastolic of 100 or greater. However, again, the literature says caution with patients that have hypertension with a systolic of 140 or greater and a diastolic of 90 or greater. So again, weighing those risks and benefits. If the patient has a current venous thrombosis and they're not being anticoagulated, that is a contraindication. If they have breast cancer currently, that is a contraindication as well. Again, though, caution with patients that have a history of breast cancer. Also, this is contraindicated in patients with a history of stroke, history of cirrhosis, history of migraine with aura, and then finally patients that have been diagnosed with diabetes for greater than 20 years. And so you can see there really are a lot of components to consider before prescribing these contraceptives, and it's going to require proper screening on your part. So if the patient has decided to start birth control and there are no contraindications, then they can be started at any point in their cycle once pregnancy has been ruled out. When a new form of birth control is started, you should instruct your patient to use backup form of birth control for the first 7 days. So combined progestin, estrogen, this can be delivered in a transdermal patch, which is changed weekly, a vaginal ring, which is changed monthly. If the patient is using the pill, there are some important education points though with this regarding missed pill or pills. So if one single pill is missed, then the patient should take the missed pill as soon as possible, even if that means taking twice or 2 at once. And then they would continue on with their normal 1 pill a day. If they miss 2 or more of their birth control pills, then the patient should be instructed to resume the 1-a-day scheduling and then use backup again birth control for that first 7 days to prevent an unwanted pregnancy from occurring. There is also the option of progestin-only contraception. This is an option for patients that cannot take estrogen. It can be delivered in pills, also referred to as POPs, progestin-only pill, or as an implant, injection, or an IUD. A commonly used POP or progestin-only pill is the norethindrone. The only contraindication includes known or suspected breast cancer, undiagnosed abnormal uterine bleeding, or liver disease. Also, patients that have had bariatric surgeries or those who are also taking anticonvulsants are advised against using these progestin-only pills as well. If patients are using these progestin-only pills, these POPs, then common side effects include breakthrough bleeding or irregular menstrual cycles. And it is essential for patients when taking these that they take them at the same time each day. A backup birth control should be used for at least 2 days if they took their progestin-only pill more than 3 hours off of schedule. And then another popular form of progestin-only birth control is the depot-medroxyprogesterone acetate, or the depot shot. This is given as an injection every 3 months. It has a grace period of 2 weeks. Unscheduled bleeding with this is common. However, it's typically not problematic for the patient. And typically when patients discontinue the depot and they want to attempt pregnancy, 50% will become pregnant within those first 10 months. However, there is a smaller percentage of women that can take up to 18 months following the depot to regain their fertility. We should also talk about intrauterine devices, or IUDs, as this is the most commonly used reversible method of birth control worldwide. There are 2 different types. There is the levonorgestrel releasing IUD. This is progestin only, and then the copper IUD, and this is sold under that trade name Paragard. So the copper IUD, this is a non-hormonal IUD, and it allows for continued menstrual cycles, and it's been approved for use for 10 years. It appears that the IUD provides contraception by inducing an inflammatory response due to the fact there is a foreign body in place. That's pretty simplified, but the overarching theme from what I've seen is that the inflammatory response, it's not only toxic to sperm, but it does impair implantation as well. And then also it's thought that the copper provides contraceptive benefits additionally. So that is a very effective method for birth control. Benefits include, so it's greater than 99% effective in preventing pregnancy. It's really, it's no maintenance after once it's inserted. Very few side effects. It's rapidly reversible. And it has actually shown to reduce the risk for cervical, endometrial, and ovarian cancers. Contraindications to the use of an IUD would be pregnancy, deformity of that uterine cavity, active pelvic infection, unexplained abnormal uterine bleeding, and then breast cancer again. Also, in the presence of active liver disease, the copper IUD is the preferred choice over the hormonal IUD. Those should be avoided in those patients. Though the risk of pregnancy with an IUD is extremely low, if a patient does become pregnant while an IUD is in place, they should be evaluated for an ectopic pregnancy, because there is an increased risk with ectopic pregnancy if the patient becomes pregnant with an IUD. The overall risk for ectopic pregnancy itself is actually lower with an IUD because the chance of pregnancy is so low. However, if pregnancy does occur, then this needs to be ruled out. It is noted that the copper IUD has a lower risk for this ectopic pregnancy occurring.